Hi guys, welcome back. The other topics we're going to cover now is male infertility, SUI, and vaginal fistula. Let's see the questions we have to address here and the subsequent answers to that. So we're going to start with male infertility. It's going to be the biggest topic, so I think probably after this we'll be good to go. So in male infertility, the points that we're going to discuss are yeah, definition of infertility, first point. Then we have causes and treatment of male infertility. Okay. Uh, Semen analysis, interpretation, WHO interpretation, WHO criteria. Then we have tubal patency test, laparoscopic chromotubation, ovulation signs, symptoms, and diagnosis, induction of ovulation, semen analysis, normal this one, secondary infertility. Yeah, secondary infertility was, do it again. Postcoital test we'll see later on. Tubal patency, dyspareunia, azoospermia, SSG, tubal cannulation, Fern test, ART. Yes, ART important. Surrogate mother, intrauterine, this one. Okay, so most of it is related to male. I'll do tubal patency test. The other tests, including induction of ovulation and some other questions here, dyspareunia and all, I'll be addressing in the next female infertility. Yeah, let's get started on the male infertility. So, definition, causes, and treatment. Let's just do it here, yeah. So, what is infertility? Infertility is defined as inability of a couple to conceive despite of 1 year of unprotected intercourse. Since it's a male, it's not something I would mention, but if it's a greater than 35-year-old lady, we will start investigations after 6 months. It gives some more time for natural fertilization to occur. If it's less than 35 years, within 3 months, we have to start with the investigation for infertility. Let's start investigation. Just one second, I would like to open the page here for infertility. All right. So we have few definitions for infertility, fecundability, and fecundity, secondary infertility. So primary infertility is never able to conceive prior. Secondary infertility is basically she was able to conceive prior, even if it's an abortion or anything, and subsequent she is not able to get pregnant. Primary is over, secondary is over. Fecundability is the probability of getting pregnant in the following within one menstrual cycle. Fecundity is probability of live birth within one menstrual cycle. Okay, so these are the definitions. After definitions, we're going to go to causes and treatment of male infertility. So we had a lot of this one for male infertility, but let's see. So if it's like a long answer, you have to read all this stuff. Like, so causes of infertility in 40 to 55% it's the women, in 40% it's the men, in 10% it is unknown, unexplained. Then, yeah, a very nice way of putting this would be areas of infertility. Okay. So infertility, yeah, this is a really nice in areas of infertility. So we have three areas. We have a pre-testicular problem, a testicular problem, or a post-testicular or obstructive problem. Fine. So causes of male infertility, it can be a pre-testicular problem, that is level 1, a testicular problem, or a post-testicular or obstructive problem. So in pre-testicular, we're going to have issues like you can see on the left here. So in a pre-testicular problem, testicular problem and post-testicular problem. I think this is a nice way to put it, but I haven't studied this, so finding it a bit difficult. Yeah, and there's one more, coital problem. So let's just list out everything we know so that we can just fill in the rest in. So pre-testicular problem, we can have problem with the GNR, this one HPO axis. So we can have Kallmann syndrome. We can have to be very honest, I don't think I can list out everything and remember everything, but let's go with things we know and things I would probably do in a hospital setting. So in a pre-testicular problem, we have the problem here in the HPO axis, right? So we can have a defect here. We can have a defect in like a Kallmann syndrome. We can have hyperprolactinemia. We can have hyperthyroidism, hypothyroidism, which would in turn raise the TSH, which would in turn inhibit the GnRH pulsatile release. Okay, so this is for pre-testicular problem. In testicular problem, we have a few. We could have a genetic issue, as in we could have Klinefelter, we can have mumps, we can have Riefenstein disease, we could have raised temperature, we could have cryptorchidism, We could have issues in mom's motility. Yeah, we could have, yeah, I think this is pretty much enough. Obstructive, we can have cystic fibrosis wherein there's absence of seminal vesicle and vas difference. We can have Cartagena syndrome wherein the sperms are immotile. We can have Young syndrome, again, absence of vas difference. We can have a few nice causes like varicocele infection. We can have retrograde ejaculation. We can think of a surgical cause like vasectomy. Fine. In coital problems, we have erectile dysfunction. We have impotence, same thing. Ejaculatory, this one, hypospadiasis. So this is probably good enough. So I think areas of fertility is a good division: pre-testicular, testicular, obstructive, and caudal. I'll draw this lovely diagram. Okay, we have hypothalamus releasing GnRH to pituitary, pituitary in turn releasing FSHLH, which goes to the testis. Then we have the Leydig cells, Sertoli cells, they're releasing their own stuff. Leydig cells releases testosterone, which in turn pushes a sperm pathway, and then it goes out to the ejaculatory tract. If it's an issue here up to the pituitary, so pre-testicular problems such as Kallmann syndrome, hyperprolactinemia, and Kallmann, hyperprolactinemia, and hypothyroidism. If it's a testicular problem, we can have a few. We could have high temperature. We could have cryptorchidism. We could have genetic abnormalities like Klinefelter's. We could have androgen insensitivity syndrome. We could have Reifenstein disease. We could have mumps. Then we could have testicular. Then afterwards, in the outflow tract, if we have an issue, we're going to again do uh, outflow tract. If you have an issue, we're going to see where we have an issue. We could have congenital, where there's absence of seminal vesicle and vas difference in Young's disease, in cystic fibrosis, a varicocele. We could have TB or some infection causing stricture. We can have hypospadiasis. We can have retrograde ejaculation. We can have a varicocele. We can have Cartagena syndrome leading to immotile sperms. And coital, we have electrolyte dysfunction and hypospadiasis. Nice. Okay, so this is the causes of infertility which we would cover. Next, what we would cover was investigations and management for uh, investigations and treatment for male infertility. So how are we going to investigate? I would like to write here only in the fertility section. There are three tests we always do. Okay, we're going to do a semen analysis. We're going to do a tubal patency test. We're going to do an ovulation test. These three tests are always done to test for infertility. So in the investigations, okay, this is how we approach it. Unexplained or abnormal semen analysis. First, we're going to do a semen analysis, okay, whatever it may be. We're going to have so many tests here, but like there should be a way you want to approach all of them. Yeah, so this is it. Semen analysis. If it's abnormal, we do a repeat semen analysis. This is followed by hormonal studies. This is followed by testicular biopsy. And then we do management. We have management based on sperm count. Okay. So it's a good outline. Uh, then we can dwell into each of them independently. So first we start with first we start with the history, examination, and then we go for the investigations. So how do we investigate? We have an history. In the history, what and all do we ask for? We ask for any sexual dysfunction, drug history, radiation history, erectile dysfunction, hypospadiasis, some drug history, radiation history, trauma maybe, these kind of things. Then after history, we do a general examination and external like systemic examination part. In examination, we are going to check for very important testicular volume and testicular size. Testicular volume is generally 15 to 25 ml, which is measured using a Prader's orchidometer. Okay, and yeah, we're also going to check for sexual development, Tanner staging of testes, of penis, pubic hair, all that. So we're done with history, we're done with the examination, then we go for investigation. This is the investigation. We start with semen analysis. And then we can dwell in detail with this. Yeah, we'll go for semen analysis with WHO criteria, and then we'll go for infertility treatment, and we'll explain the other investigations as well. So now, semen analysis. Semen analysis in itself is like a huge question, repeated multiple times, and we tend to write more. Don't write more. Write what is asked and write what is high yield. Okay. So what is semen analysis? Uh, how do we collect semen? Let's start from there. Yeah, semen. We ask the patient to have at least 2 to 7 days of abstinence. After this abstinence, we ask the patient to masturbate and to collect semen sample. Okay, in a clean mouth, white jar, glass jar, and stuff like that, and it should reach the lab within 1 hour. Okay, and then after that, we wait for liquefaction. Liquefaction for another 20 minutes. So, what are the testing we will do here? So, in semen analysis, here we're going to, yeah, here also hormonal study, testicular hormonal study, and here karyotyping. And a special postcoital test or immunological test. That's it, that's it, that's all in investigations, okay? So, in semen analysis, very important is the WHO 2010 normal reference values. So these are reference values needed for conception again and again. So the reference value needed for conception. So we're going to talk about volume. We're going to talk about pH. We're going to talk about volume, pH. We're going to talk about sperm count. We're going to talk about count per ejaculate per ml. This will be concentration. We're going to talk about motility, morphology, the WBC count, and we have something called the average sperm count. We have something called sperm agglutination. These points need to definitely be there in your answer. Okay. So, volume must be greater than 1.5 ml. What is the reference range that given? 2 to 3 ml. Okay, greater than 2 ml. pH should be more than 7.2. So 7.2 to 7.8. Sperm count. Sperm count should be at least greater than 35 million per ejaculate, and concentration should be at least greater than 15 million per ml. Okay, see, I would like to write this again because it's kind of important. Okay, so we have parameter, we have the lower limit. This is lower limit is the limit, minimum limit needed for normal conception, and then we have the range. Okay, so what and all we have? We have the pH, we have the volume. We have the pH, we have the volume, we have the total sperm count, we have the sperm concentration, sperm count, volume, pH, viscosity maybe. Very important, morphology, motility, WBC count, average count, and sperm agglutination. So pH should be lower limit, it should be greater than 7.2. So 7.2 to 7.8, let's go here. Volume should be greater than 1.5 ml, so greater than 2 ml. Then total sperm count should be greater than 39 million per ejaculate, or greater than 1.5 million per ml. Okay, so here it will become 2 ml. Sorry, it's 15 ml per ml. So here will be greater than 2 million. Viscosity should be greater than 3. Normal range is 0 to 4. It's a 0 to 4 scale. It should, listen, viscosity should be less. Less viscous, more motility, more it can reach the fallopian tube. So it should be less than 3. Okay. Let's put less than 3, it doesn't matter. Morphology, very, very most important is morphology should have at least greater than, normal is, it should be greater than 4% according to strict Tiger Burn criteria. Normal should be greater than 14% of all of them should have normal morphology. Motility, we should have, total motility should be 40%. Progressive motility should be greater than 32%. Okay. So forward motility, and this is progressive motility should be at least 32%. Important. Tiger Burn criteria important. Million important. WBC count should be less than 1 million. Average count should be 50 to 100 million per ml. And we have the sperm agglutinin count should be less than 10% should be adherent to particles. So this is as far as we go with the semen analysis. If anything is pathological in this, we go to, see, along with this we can also define definitions of some of the pathological conditions. Azoospermia, absence of sperm. Oligospermia, oligospermia grading, mild. So how much should be 15? So 10 to 15, mild. Severe, 5 to 10. Lower than 5, very severe. Okay. Then we have azoospermia, no sperm. Yeah. This can be seen in, we can have Klinefelters, we can have cystic fibrosis, we can have Cartaginous, we can have, yeah. Now we go to asthenospermia. Wherein the motility is affected. And then we have teratospermia, wherein the morphology is affected. Necrospermia, more number of dead sperms. leukocytospermia, wherein we have greater than 1 million per ml of WBCs. The senior infection, okay, like epidemitis, prostatitis, we can give 100 milligram of doxycycline for this. Fine. So this much is done in the definitions. Now we go to the next investigations. The next semen analysis, repeat semen analysis within an interval of at least 1 month. Again pathological, then we go to the next thing. So the next one is after semen analysis, we go for hormonal. After with hormonal, we have two more, karyotyping and immunological, and then we go for testicular biopsy and then management. Keep writing this; it will help. Like it will be like guiding you right through these things. I think I'm pretty much done. We just have to discuss, discuss some more investigations, management, and yeah, then we have this SUI vaginal fistula, and we'll be done with this topic, and then we can move on to the next one. There's so much to cover today, but I'm very excited to be doing RHI immunization and some miscellaneous procedures in the next video. Hopefully, should get covered in like an hour, right? Uh, so yeah, let's see how it goes. So yeah, the other investigations that we've got are, I'm sorry, do this. Do hormonal. This is really well done. Okay, we have FSH and testosterone that we're going to check. Fine. Along with this, two other hormones we're going to check. What is that? TSH and prolactin. So once we're done with semen analysis, abnormal, repeat semen analysis, again abnormal hormonal testing. So in hormonal testing, let's see 3 kinds of conditions along with 2 miscellaneous conditions. Okay, so now if we have TSH is, let's write FSH and let's write testosterone. So if FSH is uh, reduced, simultaneous testosterone will. So this will be secondary hypogonadism, and this is because of hypogonadotropism. This can be seen in Kallmann syndrome, hyperprolactinemia. So here hyperprolactinemia again will have prolactin levels will be high, or hypothyroidism. So here TSH levels will be high. Now we have FSH is normal, testosterone is decreased. This is a testicular problem, which is a primary hypogonadism. Again, we can have Klinefelter's, we can have mumps, we can have Riefenstein's disease, we can have Meniere's, we can have cryptorchidism, and so many lovely causes to be listed out here. Okay. So after finishing the FSH is normal, testosterone normal. Obviously here it will be a obstructive, or it could be a coital problem. So in obstructive we have, no, it won't be a coital problem. Why? Because in coital problem the semen analysis will be normal. In obstructive problem we can have a varicocele, we can have a TB, genital TB, we can have strictures, we can have hypospadiasis. Yeah, why not? We can have congenital problems such as cystic fibrosis, Young's disease, Cartagner's disease, and stuff like that, right? We can also have retrograde ejaculation. So this is for hormonal testing. So after this, what we're gonna do is we're gonna have two other, which is karyotyping, genetic analysis, and immunological studies. Yeah. In karyotyping, where is karyotyping done? That's the first question. So karyotyping, I think I mentioned it somewhere. Yeah, karyotyping must be done whenever there is severe oligospermia or there is a non-obstructive severe is less than 5 million obstructive oligospermia. Okay, these are two condition indications for karyotyping. Karyotyping, what you can see Klinefelter's XXY, you can see micro deletion of chromosome number Y. These two can lead to defective spermatogenesis. Apart from this, we're going to do immunological testing. So in immunological testing, we can test for antibodies against sperm. This is seen in conditions such as trauma or orchitis, wherein sperm agglutination is seen. So this is one of the reasons why sperm agglutination was there in the 2010 WHO criteria. So it should be less than 10% adherent. Yeah, so we did hormonal, immunological, karyotyping. Yeah, finally we come to treatment. That is management of male infertility. I don't think I have the time for tubal patency test. I will be doing it in the next one. Let's see. Ah, other than hormonal and testicular biopsy, again, obstructive azoospermia investigations. Right. So in obstructive azoospermia, it can be, draw this. For urethra, seminal vesicles, prostate, bulbourethral gland, penis. This is coming from somewhere else, no? Epididymis and all that. So here we could have a lesion, epididymis vast difference. We could have a lesion here. So two types, level 1, level 2. This will have, this lesion will have low seminal fluid, will have low fructose, will have low pH, that is acidic pH. This will have normal pH because it's having seminal fluid. So these two are differentiated again. Then we have ultrasound here. Okay, here if you have a lesion, no. Here if you have a lesion at the epididymis, we do an scrotal ultrasound. And the management is resection and anastomosis. So it's given very well here, just pay attention. Obstructive azoospermia, we're going to do semen analysis again in terms of sucrose, volume, and pH. So if it is level 1 here, epididymis or vas deferens, it's going to have a normal, pretty much a normal thing. Okay, and then we are going to do a scrotal ultrasound to find the lesion and resection and anastomosis with the management. If it is at a lower level, what we're going to do is uh, we're gonna check. We're gonna do for obstruction again on this scrotal ultrasound. Here we're gonna do a transrectal ultrasound. Okay, so there are two possibilities here, and there's one more possibility wherein there's no obstruction per se. There's no flow on it. The seminal vesicle is itself absent. Okay, seminal vesicle itself is absent. This is seen in cystic fibrosis. In a transrectal abdomen, we can have no obstruction. This means there's a retrograde ejaculation, and there is a dilated seminal vesicle, which is can seen because of ejaculatory duct obstruction. What is the management? So I really like the management part of it because it's based on how much you have it. How much is the degree of infertility? So the management, I'm gonna go with, if it is, what is the normal sperm count? It should be greater than 15 million per ml, right? So if it is 10 to 15 mild, here we can do is intrauterine insemination. If it is 5 to 10 million, that's less than 5 million. Less than 5 million, you can't do anything. You can't do this, all this. Here we can do in vitro fertilization, wherein we need around 50 to 1 lakh sperms per ovum. Here we do an intracytoplasmic sperm injection, ICSI. Okay, fine. I think we have to in detail explain them. I found it pretty easy, so I just explain here itself in the left: intrauterine insemination, ICSI, IUI, complication, and one note on this one: pre-implantation genetic testing. And, and then I have two more topics to cover. Yeah, I need to push a little harder now. Okay. I think I can rule these two out for now. Yeah. Oh no, I have this still left actually. Okay, nothing over for now then. Tell you what, this one, this should be done. And immediately following this, yeah, radiation and chemo for gynec malignancy, this is done. Oh, just two topics over, so much more to do. We can definitely do it. We can do it, we can do it, we can do it. I just need to do management of infertility. I think I do fistula, SUI, RH immunization, pharmac, and section 8 separately. Okay, shouldn't be too much if I'm a bit focused, I suppose. Okay, I think this is all I can push for now. Fine, let's go for management of male infertility. So, very nicely based on this. So, first one is intrauterine insemination. Intrauterine insemination, first we have the criteria of required. It's done in OPD procedure, and we weight it, we liquefy it, 37 degrees Celsius. Here we do a CASA, computerized automated sperm analysis. It's one droplet for that. Apart from that, we take the sperms and then using then we introduce it using a catheter into the uterus. Okay, here 3 points. One, this is in case of a normal, regular, perfectly healthy woman, what we're going to use is a LH kit. So urinary LH kit, and whenever her LH is high, we're just gonna expect ovulation, and so we're gonna do IUI that time. In case of irregularly unexplained infertility, we're gonna give clomiphene citrate. Gonna monitor when we have greater than 17 mm, at least greater than 3 follicles. We're gonna shift her over to HCG injection, which is going to promote ovulation, prime the uterus, and then within 30 to 36 hours of giving this injection, we're gonna inseminate her. Okay. Now, one extra point in case of retrograde ejaculation, what we're going to do is we're going to ask the patient to void urine and ask to masturbate. After ejaculation, we're going to collect the urine sample. This is we're going to treat with sodium bicarbonate half an hour prior, okay? And then from the urine, we're going to isolate the sperms. So this is in case of intrauterine insemination. Now, if it is 5 to 10 minutes, what we're going to do is IVF. So this is nothing but in vitro fertilization. I'm sorry, I'm sort of getting scared on something, but I think it's going to be perfectly all right. See, I've read a little. I'm pretty sure, like, at worst cases, I'm going to finish 80%. Definitely, I'm going to finish 80% syllabus before going. and another 10% probably not come. So I can score up to 90%, lowest I can score up to 70%. That's great marks, and I think I should just focus on enjoying the subject at this point. So yeah, in vitro fertilization, superb concept. So here we have the requirement. Same thing in the woman. So what we do is we do supraovulation using clomiphene citrate. We monitor the patient, follicles greater than 17 mm or greater than 17 mm, at least 3 follicles. Then what we do is we give HCG injection. The difference in vitro fertilization, we give injection HMG instead of clomiphene citrate. HCG injection, then 30 to 36 hours. Then what we do is egg retrieval. Once we retrieve the egg, what and all we're going to aspirate? We're going to aspirate the oocyte, we're going to aspirate the follicular fluid. Once this is done, in a petri dish, we're going to, in the same medium, we're going to mix them. So for 1 ovum, there should be 50 to 1 lakh sperms. Okay. And 5 to 20% oxygen for up to 18 hours at 37 degrees Celsius. Once this is over, we're going to see whether there is fertilization done. How will I come to know if fertilization is done? We're going to check for, in the perivitelline space, we're going to check for 2 things. We're going to see for 2 polar bodies and 2 pronuclei. Okay. Once fertilization is complete, we're going to do an embryo transfer. Embryo transfer, either D3, that is cleavage transfer, or D5, blastocyst transfer. Where we're going to put it? We're going to put it 2 centimeter below the fundus. This is basically in vitro fertilization. Then intracytoplasmic sperm injection, when the sperm count is very low. Okay. We just take a sperm, we inject it in the cytoplasm of the ovum, and we implant the ovum. Right. What are the indications of IVF? Low sperm count, tubal impotency. Yeah, this page is important. You have to sort of pay attention. Okay. What are the indications for intrauterine insemination? Cervical factor infertility. We have vaginismus, male ejaculatory problem, and we have oligospermia. Basically, coital problems you're going to have do IUI, such as cervical factor in vaginismus, male ejaculatory problem, hypospadiasis, erectile dysfunction, and oligospermia. What is the indication for IVF? A failed IUI, a failed ovulation, a low sperm count of how much? 5 to 10 million. Mullerian agenesis. In Mullerian agenesis, there's no uterus on it, so we're going to do IVF along with surrogacy. And then we have tubal infertility. I'm going to give IVF. Important, we are going to do something called perinatal genetic testing. This is important for chromosomal abnormalities. See the types, we're going to A, M, SR. M, monogenic defect, aneuploidy, and structural chromosomal defect. Okay. Apart from this, what are we going to generally? Polar body is preferred, but we cannot check for the paternal genes. We can use cleavage body, cleavage embryo transfer. In that cleavage we can use, and blastocyst we can use. Okay. Gift no longer used. What are the complications? Pregnancy-induced hypertension, placenta previa, abruptio placenta. This is antepartum hemorrhage causes. Fetal problems, most important fetal problem, they have increased risk of hepatic adenoma. And we have multi-fetal pregnancy, multiple pregnancy, so we can have intrauterine growth retardation, low birth weight. Okay, so this pretty much sums up male infertility.